Hello, everyone, and welcome to the July Links webinar. As you may have seen in my email earlier this week, we are offering for the first time simultaneous interpretation into Spanish. I want to give a special thanks to our colleagues at PAHO for making this possible. We may experience some technical difficulties, and we ask that you kindly bear with us as we test this feature. Both the English and Spanish webinars are being recorded and will be posted to the Links website after the session. Just a little housekeeping rules. The lecture will be about 30 minutes long, followed by a Q&A session. We encourage participants to use the Q&A button to ask questions. The Q&A button is located at the bottom of your screen. During the presentation, participants will be muted, but will have the option to type in questions for the Q&A portion of the presentation. Again, this webinar is being recorded and will be posted on linkscommunity.org. Now, I'll hand it over to Dr. Mark Jaffe, Senior Vice President of the Cardiovascular Health Program at Resolve to Save Lives, to introduce the topic and today's speaker.
Thank you very much, Lindsay, and thank you, Professor Podwall. It is my great pleasure to host this webinar. Let me just explain to you what LINKS stands for. Of course, LINKS is the Resolve to Save Lives program, which stands for Learning Platform, Implementation and Advice, Networking, Knowledge Exchange, and Support in the form of grants and technical assistance. We are a growing community with almost 800 members from over 80 countries. And of course, it's developed in collaboration between Resolve to Save Lives, the World Health Organization, and the Centers for Disease Control. Now, I don't have to remind many people on this call that hypertension is the world's leading killer. Globally, it kills about 10 million people every year, and that's more than all infectious diseases combined. Resolve to Save Lives, with global, national, and local partners, helps establish and scaling up proven strategies to improve the control of blood pressure. And of course, one key component of hypertension treatment is controlling hypertension, and to do that, you need to acquire and use proper blood pressure devices to ensure accurate monitoring of blood pressure results, whether you're at home, in the clinic, pharmacy, or any other place. The ideal blood pressure monitor should be accurate, should have a whole bunch of cuffs that fit the patients, should be durable, have many options for power supply, and of course be reasonably priced. So it's my honor to present today's speaker, Professor Raj Podwall, Professor of Medicine and Director of Hypertension Dyslipidemia Clinic at the University of Alberta in Edmonton, Canada, as well as the past chair of Hypertension Canada Clinical Practice Guidelines. His research focuses in technology-assisted care and blood pressure measurement. He will review the essential components for selecting an accurate automated blood pressure monitor, such as site of measurement, importance of multiple readings, cost, accuracy, usability, and particular emphasis on the low and middle income setting. Professor Podwall, take it away.
All right, great. Thank you, Mark. And thank you to Resolve and to Links for this opportunity. It's an honor to be here. So I guess the first thing I'll start out with is my disclosures. So Lindsay, if you could advance to the disclosure slide, thanks. I think this is pretty self-explanatory. The only one that probably bears a little bit of mention is the commercialization, a little bullet there. We have a University of Alberta startup, and we are working in both software and hardware solutions for blood pressure measurement. We have a software solution out called Sphygmo Home. That's a telemonitoring system. We don't have any hardware out, so I don't think there's any direct bias here with this talk, but you should know that I'm a pretty big proponent of out-of-office measurement. So if I do have a bias, I just want to declare that at the start. The other thing I should declare is that I haven't done a lot of work in low middle income countries, so I would not at all consider myself an expert. I know a fair bit about blood pressure devices, but I would be looking forward to the discussion. I think you'll probably enlighten me on a few points that may or not be feasible from what I discuss in the next 20 or so minutes. Next slide, Lindsay. So the objectives for the next 20-25 minutes are to review the BP measurement types and then go over the terms calibration and validation, and specifically exactly how do you do this when you're sitting in a clinic and trying to make sure that your blood pressure measurements are accurate. And then I'll finish off with some very specific issues for LMIC settings, as much as we could think of, or I could think of, to present. There may be more that people raise in the discussion period. Next slide, please. I think it is useful, before we start anything else, to go over these two terms. These terms are used interchangeably often, and they don't mean the same thing. And in different fields, they also may mean different things. So I think for the purposes of this talk, and maybe more generally for the purposes of BP measurement, this is what people are referring to when they say validation or calibration. For validation, it's really an issue when you are trying to determine which device to buy. And you want to know whether that device has been tested for clinical accuracy. So I'm not talking about getting a 501k of the FDA or an equivalent regulatory approval, mechanical, electromagnetic, etc. I'm talking about a clinical study that showed that that device was actually registering BPs in a reasonably accurate, acceptably accurate manner. So I'm going to go over that in a few slides, but I think it's probably the most critically important message of this entire webinar. The second is calibration, which is, I guess, equally important. Now, calibration, you'll run into that when you have purchased the device. So you own a bunch of devices, and when I say device, it could be an aneroid, sphygmomanometer as well. And you want to make sure that over time, that device is not losing its accuracy. And that is what we refer to by the word calibration and the process of calibration. And I'm going to be going over that in a few slides as well. So next slide then, Lindsay. Before I begin about devices, I just wanted to make sure we're all on the same page. I know probably almost everyone listening out there has heard this before and is familiar with this, but really the major part of getting an accurate reading is accurate standardized technique. And I just wanted to give a plug to this global collaboration that I was lucky enough to lead that resulted in a paper in the Journal of Hypertension. It's open access. And the reason why I mentioned this paper on accuracy and observer measurement and goes through all the steps of measurement is because we made it open access, and some great figures were made in South Africa. And so I think if you have a station, a dedicated area for blood pressure measurement in your clinic or setting, it's good to print out these posters, pop them up, and make sure that people refer to them from time to time. I will point out proper measurement takes about 5 to 8 minutes. If you include some kind of a rest period, it's usually recommended to be a 5-minute rest period. So it's not something that is easy to do, especially in a very, very busy setting. And so we'll talk about some compromises that can be done if there's no other alternative at the end of the discussion. Next slide, please. The other thing that I wanted to make you aware of, because this is such an excellent resource, and I think the last time I looked at it on YouTube, it only had a few hundred hits, and really this should have hundreds of thousands of hits, if not more. So this is BP measurement technique whiteboard animation video made by Johns Hopkins team. And I think, it really goes over very quickly and efficiently how to do proper technique. And I think when you think of observers that are measuring that are relatively junior or inexperienced, this is something that they can watch very quickly to learn the skills, and then as a refresher intermittently to make sure the skills are maintained. And of course, it's free and it's widely accessible. So that's something else I wanted to just give a plug to. Next slide, please. And I think I've covered this. Just ensure proper measurement and follow a protocol, create a dedicated space or station. That's really what helps to follow best practice, especially if it's very busy. Next slide, please. So now let's get into the measurement devices, and you'll notice that these are all conventional devices for the outpatient setting, which is of course the focus here. I didn't include any cuffless devices. Those are really not very accurate, so they're best considered experimental. And I would shy away from wrist devices unless there's absolutely no other alternative. One example where there may be no alternative is if the upper arm is simply too big, and you can only get a wrist device on that patient. Otherwise, you have manual measurement techniques, you have automated, and the three automated modalities are automated in the office, automated at home, and for the purposes of this webinar, especially in terms of LMIC settings, I would submit, and I'll talk about this later, that you can use the home devices in the clinic or office. You don't necessarily need an automated office device, and we'll talk about the pros and cons of that approach. And then there's ambulatory monitoring, which is probably out of reach in most low-income settings or all low-income settings. Maybe might be usable in some middle income, I'm not sure, but that is the gold standard. Now, I wasn't really going to talk a lot about aneroid, but I saw from some of the great comments that were already submitted that this is the only modality available in many places. And if that's the case, that's okay. You have to go with what you have and what's available. You just have to try to make sure that it's as accurate as possible. Of course, we would prefer automated devices, and I'll get into the reasons in a minute. Next slide, please. Now, the auscultatory technique, again, I added this after seeing some of the comments. Everyone, I think, is familiar with the auscultatory technique, although even in the literature, so you see this paper, which is a widely cited paper, and there's another paper that I just came across, did the same thing. They talk about systole, quite rightly, being the onset of the sounds, but then they mention diastole as the last sound heard, the blood pressure at which the last sound is heard. And that's not true. It's actually the blood pressure at which you first hear no sounds or the absence of sounds. So that's important because it's a different metric and it can throw by a couple millimeters the estimate off. And then again, also, if people aren't doing it consistently, it throws everything off. So I did want to reinforce that message. And then, of course, proper technique, as I've already mentioned, is super important with auscultation. Next slide, please. Now, here's the problem. Here's why we would prefer people use, if at all possible, automated devices. The problem with auscultation is very user dependent. So the observer has to be really on the ball and doing it properly in a standardized manner. This is a study of young Canadian physicians where they checked to see if they did all of these different aspects of measurement. But you will notice, and the reason why I bring up this slide is the second on the left, deflation rate. So the deflation rate was very, very poorly performed. And in this case, too fast. It's almost always too fast. And the reason why it's too fast is because of time pressures, of course. So any clinic in the world has time pressures, and it's just too tempting when you're auscultating to just go at a much greater speed than the 2 to 3 millimeters mercury per second that is recommended. And of course, the other temptation is to start taking the history or talk to the patient while you're doing the measurement. And so those are really the two Achilles heels of auscultation. Next slide, please. And then I would be amiss if I didn't tell you how much of an error there is. Usually the error is upwards. It's spuriously elevated when you use poor Oskol Tottori technique. And it's about a 10 millimeter difference in 10 over 5. So 10 millimeters mercury difference if you compare really good, well done, standardized technique auscultation to auscultation that's just general clinic type auscultation that takes place every hour of the day in this world. And I think so that's a really big difference, and it could make a huge difference in terms of management of a specific patient or group of patients. So that's why doing proper auscultation is important, and people are not confident it can be done, and that's why automated devices are more and more being recommended. Next slide, please. Now, auscultation, there are two major modalities. Of course, there's mercury and there's aneroid. I would bet most of you have no access to mercury now, and that I think is unfortunate. So I'm going to go against the prevailing wisdom here and say that I think mercury should probably not have been banned, especially mercury sphygmos, because the spills are ultra rare. I mean, most of the mercury spills out there came from thermometers, not sphygmomanometers. And these are now made with shatterproof columns. And so it's pretty hard to smash them open. And the reason why I'm a big proponent of mercury is because if the column is intact, and I would hope people would notice when it's not, if the column's intact and the meniscus is at 0, really it maintains its accuracy. You don't have to do anything else to it. And then the second reason why mercury is so useful is if you're going to do any calibration, which I mentioned at the start and I'll mention later, then you really need a mercury if you're in an LMIC setting. Otherwise, you'll have to purchase an electronic calibrator, and those devices are super expensive, thousands of dollars. And so this is why if you have a mercury lying around and haven't gotten rid of it yet, in spite of the fact that you're supposed to, don't, I mean, I'm going to give you maybe some advice not to follow regulations. Keep one around, hide one away, because you need it to calibrate your other aneroid devices. So the problem with aneroids is that they contain the moving parts, and because of the moving parts, they have to be recalibrated every 3 to 6 months. And I'm going to show you that in a minute. Much better than nothing, but if you are using aneroid and you've never calibrated them, which happens a lot, in my clinic in Canada here, I don't think the aneroids have ever been calibrated since the building was built. And so I don't use them. I don't think anybody uses them. We use automated devices, or we have other means like a green light, which is, and we have mercuries as well. So, so I think overall, if you have to use aneroid, that's fine. Just make sure it's calibrated if you at all possibly can do that. And next slide, please. Awesome electric devices. So kind of a busy slide. I don't think you need to get into the details about how these devices measure BP, but I do want to emphasize the point that the different devices do it differently. And so when people talk about bringing a device into a clinic and checking it against another device, assume that the clinic device has the better oscillometric readings, that may not be true. So these different devices have different algorithms. The algorithms are all kept secret and hidden and are specific to each manufacturer. And they estimate BP. So I talked about how Korotkov sounds delineate the systolic and diastolic. And so those are very specific, easily recognizable in most cases anyway, discrete phenomenon, whereas you don't have that with oscillometry. And because of that, you do have to make sure that you're using a device that is validated, because that means that in part that algorithm has been validated. And you can't really compare between the devices or expect them to be exactly equivalent, because those algorithms can be very different. Next slide, please. Why is automated preferred? I've already touched on most of this because auscultation often improperly done, because auscultation often means aneroid, and if aneroids are not calibrated, they're out, guaranteed. Also because automation standardizes the measurement process, so it takes away the need to do all of the maneuvers required with auscultation. And there are, of course, still many things left to do with measurement, like proper positioning, proper cuff size, etc. But at least it standardizes part of the measurement process. And then the other critically important advantage of automation is many measurements can be taken over time, especially in the out-of-office setting. So that's why out-of-office measurement, home or ambulatory, is so powerful and so accurate at assessing the true blood pressure of the individual. Unfortunately, out of reach in some or most LMIC settings, which is too bad, because I think, you know, everyone in the world should have access to good out-of-office measurement. That's one of the things we're trying to work on here at the U of A. Next slide, please. Now, I mentioned off the top, and there was a question submitted, and it's an excellent question. Do you have to buy an office quality unit? So examples of office quality units would be the Omron HEM 907, the BP True, the Microlife Watch BP Office. A&D has a device, I think Welsh Allen. So lots of companies make these devices, and they'll charge about $400 to $500 US. In Canada, we expect to pay about $800 US for these devices. They have more robust componentry. They have nicer cuffs. They will last approximately 3 times as long as a regular home unit, but their accuracy is probably not any better. And the reason is because the algorithm in the office devices almost certainly, I mean, I don't have direct proof because the algorithms are all secret, but almost certainly those algorithms are the same as in the home units. And so, so if they last 3-fold longer but cost, you know, 10 to 20 times more, do you have to buy an office device? Probably not. You can go with a validated home device, which, as you can see on the top of the slide, is much more reasonable in terms of cost, and may not last as long. Estimates that I've seen, 30,000 inflations for a home BP unit, 90,000 for an office quality. But if, you know, this is a really reasonable compromise if necessary. Ambulatory monitoring, I put that in for completeness, but I won't discuss it any further. Next slide, please. Now, there was a question submitted about, do you always have to take multiple readings? Well, I mean, you don't always have to do anything, really. You have to do, you can do whatever is the best for your situation and try to maximize the accuracy of your readings. But these data come again from Canada. I guess I'm on a little bit of a patriotic bent this morning. So you see here how 99 patients, no treatment given to them, 7 months of follow-up. You see over time what happens to the blood pressure as people are followed and not treated. The blood pressure is often quite high on the initial visit and then comes down and reaches a nadir around visit 5 or 6. So the bottom line message is, if you really want to get an accurate assessment of an individual's BP, and you're going to do it by serial office measurements, then you're looking at waiting about 5 or 6 visits before having a great assessment. And I mean, who's going to do that, even in high-income countries, let alone LMIC? I mean, with the clinic volumes, etc., it's impossible. And so what happens a lot is you see that visit 1 reading, people are treated and managed based on that reading, which is the absolutely wrong thing to do. And this is why getting a home BP series or an ambulatory monitoring study is the way to go, if you at all can do that. Next slide, please. I think I've covered this, so next slide, please. Now, this is a great document. I just came across this document recently, and I put the URL down at the bottom so people can just grab it and type it in or put it into their browser and come up with this document. And if you have any problems finding it, please email me and I will send you the document. My email is my first initial R, my last name, rpadwal@ualberta.ca. So this document goes over calibration, and that's a super important, in addition to validation, super important topic. So next slide. When you're doing a calibration, this is how you do it. It's not really complicated. So I hope I'm demystifying calibration here. You just need some kind of a rigid cylinder and you need some Y tubing. And you can see how they're connected in these diagrams. One on the left is an aneroid is being tested, and on the right, a digital. The automated devices should have a calibration mode that you can enter into before you hook everything up. The rigid cylinder can be anything. It can be like a lead pipe or anything that'll hold its shape up to 300 millimeters of mercury, a thick glass bottle, whatever you have. And you just put the cuff around that, you connect it up as shown in the diagram, and you inflate it to about 280. And you just check to see, make sure there's no leaks in your system. So it should stay at 280. And then you go up to 300, and then at 300, you have to have a partner helping you with this. You call out on the reference device, you call out it's at 300, and then your partner can look and see what the actual device under test is at, and so on and so forth. You go down by 50 to 250, 200, et cetera, et cetera. And by doing this, you will be able to tell whether it's within 3 millimeters. I should have put that on the slide, actually. It needs to be within 3 millimeters to be at each blood pressure point to be considered accurate. And if it isn't, then it's drifted, and especially the aneroids drift over time. The aneroids can be adjusted by, some of them have simple screws, some of them you have to take the faceplate off and just adjust it manually. But there are ways to re-zero aneroids. For electronic devices, this is the real drawback of them. You typically would have to send them back to the manufacturer, which is another reason why I would recommend in the clinic setting you not purchase really expensive automated office devices. Instead, maybe just go with home units, because if you use the home unit and then over time and you find it lost its accuracy, you can just replace it. That's probably the easiest thing to do than sending it back. I will also say, though, that we don't think electric or automated devices require a lot of calibration, and that's simply because of the way they work. The only thing that would probably go in terms of componentry is at the pressure transducer and the cuffs, of course, but the cuffs you can see when they're worn out and need to be replaced. And the pressure transducer, from testing that I'm told by many different companies, it doesn't really drift over time unless that unit has been damaged in some way or dropped. And so probably the automated devices, oscillometric ones, they probably don't require a lot of calibration, but it's still important to be able to test them to make sure. Next slide, please. So the validated point I've actually made, but I want to go into a little more detail, and I will drive home the point. Although this is not empiric data, it is estimated that a small minority of devices on the global market are actually validated, and that's a big problem. And so we're working on that, headed by James Sharman. We're working on this problem. There's a big global consortium trying to advocate for validation. Next slide, please. Now, what is validation? Because I just told you what calibration was, but I think people may not have a good idea of validation. So we do validation studies in our center, and this is roughly what we would be doing in a closed room that's very quiet. What you do is you have the device under test sitting on a table, and then the subject across from that. And then you'll have a mercury reference. Sometimes people use 2 mercuries connected with a Y connector, or if it can be easy to be seen by both observers, just one is fine. And you do blinded measurements, and you take 9 readings, and there's a supervisor that ensures that the observers agree to within 4 millimeters. So the reason why I'm telling you all of this is to show you this is what clinical validation is. And so, you can't accept a 501k, you can't accept a quality assurance certificate showing that their QMS was in order. Like, these are not validation documents. They're important documents, of course. You need a company to be doing proper QMS internal structure, and you need them to get a 501k or an equivalent in their country. That means that the mechanical and electrical, magnetic, and all of those other things are up to par. But clinical validation is an absolute must. And when you talk to a company, they may send you stuff in the first bullet, and they've never done this last bullet. In fact, sometimes they may not even know what a clinical validation study is. So this is what we're referring to when we say buy a validated device. I will also say that clinical validation is expensive. And when you're looking at companies that are in LMIC settings, it's tough. It's tough to ask them to pay that much money for a clinical study that may actually fail. And that's why we see the reticence on the part of some manufacturers to even go down this route. 40 to 50,000 US is a typical cost for a validation study. And I would say one thing that I want to help with, and I think others are interested as well, is we really have to get some local expertise in each country so that that cost comes down, and then local manufacturers are able to afford validation studies. And that way we improve validation across the world. Next slide, please. There are different validation protocols. You don't have to know the nuances of these if you're not interested. What you do have to be able to look for is that one of these was used in the validation that has been done with that company's device. So backing up a little, I'm talking about this when purely from the point of view of when you want to purchase devices, and we tell you buy validated devices, and you come back to us and say, well, what does that mean? That means that if you're speaking with a company, you ask for their clinical validation study, and they have to produce one according to one of these protocols. The one that's going to be used most often now is the ISO 2018 protocol. But I still accept these other ones. In Canada, we still accept these other ones because any validation is better than no validation. And in fact, the BHS and the German ones are quite rigorous. Next slide, please. The other way to find out, you don't have to review a clinical validation if you don't want to. You can just go to listings and make sure the device is listed in the listings. Sometimes you'll need help from the company because they rename the model number in your local market, and then, for example, the Canadian markets, it's the same device, but it's called a different thing. And so I won't belabor this. I mean, here are lists for you, and these, you may not find your device on all these listings, but if you're looking for a commonly used device, it'll probably be on these listings. Next slide, please. And in case you are looking at clinical validations, I've underlined this substantially or salient essential elements of what you're looking for. And I won't belabor this again, but this is the kind of thing that you want to look for to make sure that a device is validated. Next slide, please. So here's the conundrum from the LMIC viewpoint, and that is that major multinationals often validate, and their devices, though, are more expensive often than locally produced devices. So the conundrum is, if you're going to buy validated devices, you may have to pay more, and that really sucks. But it's the reality of things right now. Until we're able to try to help local validations occur. These companies are good companies. They usually validate most of their devices, if not all of them. And so if we're asking you to buy validated devices, in no uncertain terms, we're kind of almost always pushing you to buy these devices for now until we have other locally manufactured devices that we have good validations for. Next slide, please. Now, issues specific to LMIC, time pressure. That's a huge one. Lack of dedicated space and inability to purchase all the equipment you need. So I've covered some of these points, but you know, because it's a standardized technique, you want people who are well trained to do it. And so you want the same person or persons doing it, even though it's a bit tedious. That ensures that the best technique is used every time. Secondly, put posters up to remind people. So it's good to have a measurement station or measurement area within the clinic environment where the BPs are done, if possible. If you don't have time to take multiple readings, it's just way too busy and it's not feasible, and you can only take a single reading, then it's probably the best advice is if it's normal, if it's within normal limits, the reading, then you don't have to do anything more, because the direction of bias usually in the clinic setting is spuriously elevated. And so if the initial reading is normal, leave it, move on. And then the second and third readings are only done, if you can do even 3, if the initial BP is high, to ensure that it remains high. The other thing is you may not have all the cuff sizes. And if you don't, then just choose the cuff size that cuffs most of the people that are seen in that clinic and go with that. And so you're going to undercuff. So if you're using too big a cuff, what's going to happen is the blood pressure is going to be spuriously lower. And if you're using too small a cuff, the blood pressure is going to be spuriously elevated. But you do have to accept that if you have to compromise. Sometimes compromise is necessary. Next slide, please. This is a great paper. It's pretty dated, but it still remains a great resource in terms of correcting. If you want to ballpark a correction, this correction factor is added or subtracted to the measurement. As I've already described how the direction of bias, so then the correction is opposite to the direction of bias. So I included this as well for your reference. Next slide, please. And I'm almost finished here. So then the other issues would be the environment, so hot or humid climates. And we don't really know the effect on the automated devices, even the Android devices. Probably there's an effect, but we're not sure. I can tell you that most of these devices, according to IEC regulations, which most companies follow, most of these devices have been tested up to, I think it's 45 degrees. So the initial testing was to test them up to 45. And so that's probably a reasonable level, but it gets hotter in certain places, of course. We're actually incidentally doing a little student project here where we are baking devices, automated devices in ovens and seeing if that makes a difference. And so far, although we're not done yet, so far it hasn't made a huge difference. It's not a perfectly generalizable study because we're only putting them in the oven for a couple hours, and some of these devices will be used for years and years. But having said that, it, I guess, speaks to the importance of calibrating as well. The next point is about power and batteries, and you see the different options that are possible. Sometimes only auscultation is the option. Sometimes you have solar powered options. They obviously have to be low cost though. Another option that's used, I think, pretty commonly is a semi-automated device. And you'll see that term in different contexts in the literature, but what I'm using it for is to describe a device where it has a manual sphygmomanometer pump on it, and you can pump up. So you really have done away with the need for a power for inflation. And then deflation is just passive, and then it gets you a reading. So, but it is an electronic device, so you're not required to learn the technique of auscultation and master Oskol Tottori BP. So an example is there's a Microlife cradle, I think it's called. That's an example of that kind of a device. And so that's a reasonable option if batteries are not available and power is lacking in some places. Next slide, please. So I guess I'll wrap it up there. I won't read out the key points. I think I've beaten them to death, but you know, they're there for you to review, and maybe I'll stop and hand it back over to Mark, and we can have questions and comments.
Professor Padwal, Raj, that was a terrific presentation and summary. And so I'd like to invite everybody to submit their questions using the Q and A button, and we encourage you to ask questions, and the participants will now be unmuted, and the webinar is being recorded and will be, of course, posted on linkscommunity.org. Lindsay, did you have anything else to add before we take the questions?
No, that's it. Just that we ask that you use the Q&A button and not the chat feature in order to submit your questions.
Great, thank you. So let me ask one question to Dr. Podwall. In our experiences, not only in low and middle income countries, but also in middle and high income countries, there's often a resistance of doctors and other health professionals to use an automated device. In other words, the first blood pressure is often high using any device, perhaps an automated device, and the second blood pressure, perhaps taken with an uncalibrated Android device, is lower, and that may be due to just the fact that second blood pressures tend to be lower or for some other reason. But there tends to be a resistance to using technology, and I'm not sure if it's because, you know, laying the hands on the patient makes things better or something like that, but it's surprising that I was surprised to find more resistance than I had anticipated in embracing new technology. Could you comment on this and perhaps suggest any techniques or strategies to share the word that automated is better than manual?
Yeah, thanks, Mark. I think the resistance is multifactorial. Often people have had buildings being built in clinics where the one in charge of building the clinic has auto put in Android, and so so then people feel they should use that, and certainly that's what's happened here in Canada, but we don't use them anymore. I think the other thing is people may have had bad experiences with some automated devices, probably ones that were not validated. Remember my comment about it being an estimate, and so sometimes it is off in some patients, but the magic of automated is the ability to do readings and lots of readings without the provider needing to be there necessarily. I think I would encourage people to, at least if you've never tried an automated device, get a validated, just buy one home. You know, 20 to 50 bucks is usually the cost in LMIC settings. A validated home device, and try it out and see how it can save time. Yes, there are some drawbacks to automated, but the biggest drawback to Oskol Tottori is that the technique is not done properly. And despite decades of research, and there are training, we have documented that training helps, but you know, really then I would pose the question to someone who's resistant to automated. I would say, are you going to ensure that your Androids are calibrated every 3 months? And are you going to ensure that your team gets a repeat seminar every 3 months? And I think when you stack those two things up against just simply using automated, it's probably automated comes out on top. Of course, you still have to have proper technique with automated as well. But as I mentioned before, because some of the harder elements of BP measurement are protocolized through automation, it does take away some of the error.
Thanks, Raj. Looks like we have another question, which is, how do we convince people regarding the difference between the digital and manual blood pressure cuff? It is very difficult in low resource settings. Please suggest how we tackle these issues in a low resource setting. There is always a difference between two people, and people are confused, which is correct.
Yeah, so I didn't mention this because it's kind of a complicated issue, but I'm glad somebody brought it up. I probably don't have the best answer or a definitive answer, but I can tell you what we do. So I think what this is alluding to is sometimes people have automated devices, and the device reads a certain number in them, and then they come to their office, physician's office, clinic, and they get a manual measurement, and it's not reading the same. And then the question is, well, which is right? So there's so many variables involved, and blood pressure physiologically and naturally fluctuates as well. Then the only real way to determine which measurement is correct is to compare them to two-observer Mercury, like I showed in the slide, doing 9 measurements. And of course, that's completely unfeasible in any setting, whether it's high or middle or low. You're not going to have 2 observers walking around helping to determine this answer to this question. I think that the bottom line is I would still recommend automated, because there's just so many other biases that creep into a manual measurement unless you're using the best technique. But then you still have the dilemma of, okay, you have this patient who's purchased, or maybe you're using this automated device, and we do know that about 20% of the time it may not be that great in that specific patient, whether it's due to an obese arm, whether it's due to vascular stiffness, whether it's due to pregnancy, old age, whatever. And so then what I do in my clinic is I will take their automated device and I will put the cuff on and push the button to initiate a measurement. And then I'll put my stethoscope on the brachial fossa to listen at the same time. And unless the deflation rate is really rapid, you can get a reasonable sense of when systolic and diastolic are. And of course, the devices usually count the numbers down. That's why you're able to see the display and roughly determine an auscultatory measurement simultaneous with a automated measurement. If you can do that process, you can get a sense of how accurate or how reasonable that device is. If it's off by more than 10 on consistent back-to-back readings, that may not be a good device for that patient, and you may have to use another device. Now, on a practical level, can you afford to get another device? That's another question. But I think the bottom line, if you can't, is I would still continue to use automated and get lots of readings. And if that's not an option and the device is simply not accurate in that patient, then you would default to manual, because it is a known problem in about 15 or 17% of individuals that automated may not perform as good as it does in the studies.
Thanks, Raj. I have another question here, and I will read it. And it's from Africa. And one of the callers asks, in Africa, do we have institutions that can help in calibration?
You may. I don't know the specific circumstances of Africa. This is where my lack of experience is a hindrance. So some countries do have access to that kind of service, but I guess it would probably depend on country to country. That's why I was trying to show you a pretty effective and easy way to do calibration. But I mean, I'm not sure it's feasible for everyone to do. A Y connector is usually able to be sent to you by the company that you purchase automated devices from. So they will often send you Y connectors for free. So if you have a Y connector and then you have your automated device, you just need to know how to put it in calibration mode. And aneroids, you don't have to put in a calibration mode. You just have to hook them up using the Y connector. Then the only other thing you need to perform calibration is a reference monitor. And so I mentioned earlier, then the cheapest and best is Mercury. So I guess instead of depending on the service in your country, which may or may not be available, you can easily do it yourself. But you do need that missing element, which is probably the Mercury. And so that may not be available, but hopefully it is in a lot of places still. That's the best I can answer. We are trying, I think I'm doing some of this work, but others are as well. I think we're trying to get validation on the radar screen of many places. And I think a natural flow from that would be to advocate for centers that could perform this kind of thing so that providers don't have to. But I'm not sure it's it's established in many places in low middle income. I'll finish by saying in our hospital, I mean, I'm so lucky. I have a clinical engineer that does every 6 months, looks at all the devices on a rotating basis, and then performs the calibration testing.
And thanks, Professor Padwal. And Raj, I assume that the need and the frequency of calibration is reduced as you move to more automated, as you move from aneroid manual to automated devices. Is that correct?
Yeah, and maybe I hope that came out during the talk, but just to reemphasize, we don't think automateds require a lot of calibration just by virtue of how they're built, unless they were traumatized at some point. Whereas aneroids always require calibration, 100% within a few months, you'll have to calibrate.
And I want to ask a question which we just received, which I think is a philosophical question. So Raj, Professor Padwal, put on your professor of philosophy hat. In Africa and West Guinea, there is no calibration. Do you think that based on the scarcity of resources, it is useful to use the manual cuff instead of an automated device? And perhaps you could share this, you could talk about the trade-off between using an uncalibrated device versus using nothing at all.
Yeah, I would still use an uncalibrated. So I think what you're alluding to is if you have no automated devices and you have some existing aneroids and they've never been calibrated and you can't get them calibrated, then what do? Do you just not measure BP, or do you use what you have, which is uncalibrated, likely quite out aneroid devices? And I would say the latter, because at least you'll still be able to pick up an assessment of whether someone is at 200, for example. And that's important. That's super important, right? So you may be plus minus 20 in your readings, but at least you're getting some information, and you're able to manage people that have, the severe elevation, moderate to severe elevation. So I would still use them. Great.
Thanks, Raj. And I think we have time for one or perhaps two last questions. This is from our PAHO friends. Muchas gracias. Are there issues with devices based on the different populations in whom they have been validated? Some ministries are nervous because a device has only been validated for a specific population. For example, pregnant women or elderly, and then I would also throw in people of different, from different parts of the world.
Yeah, great question. I would say that there are specific populations where you have to have devices validated in that population. And the short list, I would say right now, would be pregnancy, because there's such a change, and kids. Although some of the manufacturers swear that kids are the same as adults, but I don't think so. I don't think so at all. And so you would want to try to get devices that are validated in those settings. I don't think there's much out there for kids, to be honest. And kids, you might end up doing auscultation in a lot of them anyway. But for pregnancy, there are a bunch of devices that are validated, and I would try to get one of those if you have the means. If you don't have the means, just use what you have. I mean, it's probably out by about 5 to 10, but at least you're getting reasonable results. So that's what I would say. Now, the broader issue of should you have a device for a specific population? Well, only if you can afford it, right? But there is definitely an issue with certain types of populations. AFib would be the other one. We don't know what to do with AFib, because all the devices are out, but so is auscultation as well. So work with what you have, but the biggest population where you want to try, if you have the means to get a specifically validated device for that population, would be pregnancy. And then beyond that, ethnicity and vascular disease and age and other things, I think it's expecting too much. I would just use what you have for now.
Thank you. And we have time for you to respond to one last question briefly, and that is it advisable to give intervention dose immediately once pressure starts going up?
Yeah, so this is more on the end of therapy, and it really depends on what the pressure is. So if the pressure is in the 140 to 180 range, you know, maybe the 90 to 100 range, I would say no, you probably want to get more readings. If the pressure is, you know, 180 plus, you know, especially in the 200 range, and 100 plus, especially above 110, you're probably not dealing with white coat effect. And unless there's another reason for the pressure to be up, like pain, injury, urinary retention, etc., then you're probably looking at treating that person, because they're probably not going to come down. But when you treat them, though, treat them, follow them up frequently, and treat them gently. Don't slap on two drugs at maximal doses. Just start with a one drug half strength and then move forward from there.
Great. Well, Raj, thank you very much for that great presentation and the excellent response to the questions. I encourage everyone who joined us today to go to the links toolkit for additional information and resources on blood pressure devices, many of which Dr. Podwal has referred to today. Please note that we will not have a links webinar in August, and that our webinar series will resume in September. I want to thank everyone for joining us today and making the links community a wonderful place for resources such as this excellent presentation. And I encourage you to visit the links website to see all the other resources and to connect with everybody who is also committed, like you are, to reduce the burden of cardiovascular disease throughout the world by reducing blood pressure, eliminating artificial trans fat, and reducing salt consumption. Thank you very much. Goodbye.
Thanks everyone for joining, and a special thank you again to our colleagues at PAHO for piloting this Spanish translation. Enjoy the rest of your day.
Thank you.
Thank you.